Evening, everybody. Can you hear me okay? I'll try and speak at a level that you can all catch me. So thank you for the introduction. Thank you for the invite. I'd like to very quickly start by asking whether any of you, as long as your name's not Neil Mortimer, have heard of the summary care record. Fantastic. That's brilliant. Okay, my second point is I've decided not to go with PowerPoint. I've gone with an alternative. It does move around the screen a little bit. So, and looking at this auditorium, there might be an element of motion sickness involved. So, I work for Health and Social Care Information Centre. For those of you who don't know, they are commissioned by NHS England to deploy national health services throughout England. And I knew I'd pressed the wrong button at the first time. I should have stuck with that one. That was the one. There you go. So, there are a whole host of different publications that talk about integration. Every event that you go to talks about how do we integrate healthcare systems. This was one a colleague shared with me recently, a Kellerman report from the US that says, what will it take for us to use IT properly within healthcare and share information? And some of the points that Kellerman picks out is that there's some sluggish adoption of health IT, systems are not particularly interoperable, and people have not really given a great deal of thought to engineering or re-engineering their care processes. Just some highlights we sort of picked out. I'm going to do that again, aren't I? There we go. So, interoperability. Most of us that are involved in healthcare have heard this buzzword flying around, and just really talks about here that the data should be stored. If it's stored in one IT system, it should be available, not necessarily retrievable, but certainly available by others, subject to patients saying, absolutely, I'm happy to share my data. It should be easy to use. That pretty much speaks for itself, but it should be easy for clinicians to use. It should help the work that clinicians do. It should be patient-centeredness, which I just loved because of the Americanization of a word that I'm not even sure exists, but I kind of get the sentiment that it should be thinking about the patient. And concludes that whilst IT is okay at the moment, more work needs to be done, but the solution itself is not within IT. Providers need to think about how they re-engineer what they do at the moment to incorporate this IT. So, for those of you who haven't heard of Summary Care Record, or even those of you who have, it's had a long history. It's been something that has been challenged a number of times, certainly in different circles, simply because it is sharing patient data. Some of the myths around it, certainly one of them, has kind of been busted recently by the Care Quality Commission, who have said, actually, this is a thing that should be considered. It should be used. Fortunately, Nigel goes on in his article to actually tell people what it is, which is going to help me in my presentation. So there is a core of information that's held within your GP practice record about you as a patient. Details of any medication that you're on, long-term medication, acute medication, anything that's been discontinued, any allergies you may have, or any adverse reactions that you may have to medication. So it's very medication-centric, certainly has been. Information's uploaded to a national secure database that's known as the SPINE, and then it can be shared electronically to other users who have got the right access with the right security device, which is an NHS smart card. It can contain additional information. We'll go on to that in a little bit later, depending on whether I get the hand raised. If both the patient and the GP think it's a good idea. And people have been asking us about, well, how do we support things like long-term conditions? Can it hold information about that? Different data sets can it include? Benefits for patients have started to come out, certainly in terms of acute pharmacy, efficiency savings, safety savings, and certainly the patient experience for patients who, when you ask the question, is it okay to look at additional information about you, they kind of go, well, can't you already? So it tends to be the most common answer. We have yet to have someone say no yet, to say in response to that question. So the CQC have looked at it and said, Well, we'll see evidence of the use of this as an indicator of an organisation's efforts to improve patient safety and the quality of care, which is what we believe as a programme is what we're about to deliver. So what does it look like? And I appreciate that looks tiny, but fortunately with the technology we can kind of zoom in. So this is what it would look like electronically if someone opened your summary care record. So it would give information about you as the patient, where you live, where your doctor is, any allergies you may have, and what medications you may be on, whether they're acute medications or whether they're repeat medications. Anything that's discontinued is down the bottom of the page. You can see this is relatively straightforward, laid out. It's not a full detailed record. We don't have to go searching. We know what information is in there and we know how to find it. As the program is moving forward and we can add additional things into this, it will be laid out in a similar way and appended to the bottom. I've seen examples of what that looks like and it looks really good. I told you about its brief history. Obviously it didn't start particularly well. There was a lot of challenge around the times about sharing patient information. This has not necessarily been reduced the concern, just understood a little bit better about how to do it properly. I'd like to say I joined the program in 2011, just as things started to get good, but that wouldn't be fair. I joined in 2012. At the moment, we have just short of the magic 50 million that we're looking for. I think it's next week. I'm not even sure I'm supposed to tell you that. And in December last year, we created 1.5 million of these for patients. So we've had a really good year, certainly in 2014 to 15. So who looks at it? Who are the types of organisations that would look at this information? So naturally within primary care, we've got GPs may look at patients that are not part of their own practice. Minor injury units, out of hours, it's primary places to look at this information. Walk-in centres, anywhere where you haven't got access to the GP record. In secondary care, ambulance trusts obviously, but certainly hospital pharmacy, who are one of our biggest users at the moment, simply because it has the information in that they would want. Benefits information that I talked about earlier, we have examples of where the SCR provides improved safety and efficiency and certainly effectiveness within places like out of hours. We have these examples. And obviously social media, there's different people on social media with examples saying, actually we should just be using this everywhere, it should be mandated. We have a number of case studies and a number of promotional material that we can share for anyone who wishes to use it and to explain what that looks like to patients. So an example there of someone's ill, is taken to hospital, they're not quite sure their condition is based on the medication they're on. A check of their summary care record can give that information to clinical staff to help them make decisions. Events for pharmacy, because we're currently running a pilot for community pharmacy. In fact, one of their events is taking place in about half an hour's time, I think. That starts with a couple of my colleagues. So there's stuff happening about this all of the time. How are you doing in the Midlands? I thought I'd bring a Midlands chart up. The yellow is where we're engaged with different acute trusts within the region, and green is where it's actively deployed. So as you can see, within the majority of acute trusts within the Midlands area, it's been taken up in pharmacy. The ones that are greyed out is where you might not have a minor injuries unit or a pre-op assessment. The figures here are an indication of what the average viewing figures for patients' summary care records are on a weekly basis and what we believe the potential is. And it kind of goes on to explain a little bit as to why I'm here and why I'm doing this type of presentation. So our belief is that those figures are not high enough, so I'm here blatantly on a sales mission. And our belief is down to the fact that people are still unaware of what the summary care record is, or whether they actually recognise they have access to it. So we've got a problem with sort of user adoption and clinical take-up. I don't know whether that rings true with anyone else. Some of the reasons around what we believe this might be, it might be there's a lot of competitors, a lot of people on the market, and we're not here to try and sell something different to people, because the summary care record is free. So there's kind of no charge. And it happily sits alongside local sharing solutions too. How am I doing for time? Fabulous. Is it integrated into existing systems? It can be, and it certainly has been in certain acute systems. If people are familiar with a system called Lorenzo, which is a fairly major patient administration system. It's integrated into there already with the opportunity to be integrated elsewhere. I'll speed this up. It's not enough information on benefits. We've got information certainly on our website about what the benefits are, and we're always looking to places to do benefit studies. Is it written in policy? I've kind of drawn a stick there to try and represent, do we want actually to be written down so it's made mandatory? It would make things easier, but we believe the product's good enough in itself to not need that. People do not want it because it's free. Well, this is a snapshot of my actual phone, and I've got the majority of my applications that are on there are free, and they're all very good. Maybe not Facebook. So, why am I here? I need your help. What do I need your help with? These items. I need to be able to raise awareness. I need people to understand what it is. I need to speak to commissioners. Anyone in the room that's a commissioner, I'll speak to you afterwards if you've got 2 minutes, to work out how do commissioners consider this free solution as a data sharing option for them going forward. It needs to be embedded within existing processes or included in those processes, and I need to start to meet the likes of people in this room to build up networks of influence to get this promoted. All done.